I'd like to introduce our next speaker, Dr. Debbie Stephens. So in addition to being one of our CLL expert faculty here at the Huntsman, she also serves on the CLL guideline panel for the NCCN, and she's also a member of the medical advisory board for the CLL Society. So welcome, Dr. Stephens.
Thank you all so much. Thanks to Dr. Hu and Natalie for the great talks. And I think I am sure that there are going to be a lot of questions about COVID-19, as that's a really timely topic right now. And so hopefully we'll have plenty of time to answer all of your questions at the end of the presentation. Also, just thanks to all the patients who are joining today. Looking through the list, I do recognize several names. So thanks for joining us today, and I hope you can learn something new about the new advances in CLL. I'm going to be talking about, in general, CLL treatments and clinical trials. Again, it's kind of a lot to cover in about 30 minutes, but hopefully we'll have plenty of time for questions once we're done. So the items that I'm going to be covering today include CLL treatments, including the goals of treatment and the types of treatment, CLL clinical trials, for example, just what is a clinical trial, recommendations for first treatments and for treatments at the time of relapse. So first, I want to spend a moment just talking about the treatment goals of CLL. And as you all likely know, at this time, there's no cure for CLL except for a bone marrow transplant. And a lot of patients are not candidates for bone marrow transplants just because they're very toxic therapies. But I don't want that to be a detriment to us, because we do know that there are several very, very good therapies, and CLL can be nicely controlled in most patients. And I also want want you to keep in mind that my hope is that during some of your lifetime, we will have a cure for CLL, because we continue to do research in this area. And so right at this moment, the main goal of CLL treatment is to get you into remission. And what remission means is there's no evidence of active CLL, and we want that for the longest time possible. And so whenever we talk about responses, we may say that you have a complete response, which that means that you have completely normal blood counts. The lymph nodes and the spleen are completely normal size. Or you might have a partial response, which means you have a more than 50% reduction of white blood cell count, lymph node size, or spleen. Stable disease, of course, means no change, and progressive disease means there are new or worsening areas of disease. I wanted to include one slide on something called MRD, because you guys may have read about it and are wondering what is it and how do we check it. MRD stands for minimal residual disease, and this is basically a brand new study that is designed to detect very small levels of CLL. The majority of items done now the tests are done by flow cytometry, which is a process where we look at your blood and we look for those markers that Dr. Hu talked about and just detect if there's any really small level of disease. There are also other methods. There's a company named Adaptive that just got an FDA approval for this test, and so it's really brand new technology. When we say MRD negative, it actually means MRD undetectable, meaning we can't detect any disease, but that just means that it's only as sensitive as our tests are. And so meaning there may be a very, very tiny level of disease that we can't detect, but it really indicates a very deep response. And several of our clinical trials look at, they have found that if people are MRD undetectable after certain treatment types, they have longer survival. And this is particularly important in treatments like standard chemotherapy that I'm going to talk about here in a few slides, and venetoclax-based therapy. Really, there has not been a benefit in ibrutinib or acalabrutinib, these BTK inhibitor therapies, just because there's differences in the way the drugs work. So again, most of you know that general treatment options for cancer. In general, since it's a blood cancer, we do have limited options. And of course, as a blood cancer, we typically don't do surgery except for at diagnosis. We may need to take a lymph node out. We typically don't do radiation, either because, of course, with it being a blood cancer, we would have to irradiate most of the body, which would be very toxic. And this is typically reserved only if no other therapies are working and we need to do it for palliative reasons. And so really we're left with chemotherapy, and that's the most rational and best way to treat CLL, because if you're going to treat a blood cancer, you need to put something into the blood that's going to reach all of the blood. And so I'm going to talk about kind of classic or standard chemotherapies, immunotherapy, and targeted therapy. So when I talk about classic or standard chemotherapy, this really involves a non-specific killing of growing cells. Essentially, cancer cells are going to grow more quickly than normal cells, and so most of these standard chemotherapies are just targeted at killing rapidly growing cells. And so basically the chemotherapy goes in and it kills the cancer cells, but it also kills some of your normal cells, and then your body repairs and helps the normal cells to grow back. And that's why I have this picture over on the side, because you know that hair is something that grows more rapidly in the body, and so it often is affected by chemotherapy. When we talk about classic or standard chemotherapy, I mean drugs like fludarabine, cyclophosphamide, bendamustine, pentostatin, or chlorambucil. And you might recognize fludarabine and cyclophosphamide as part of a regimen called FCR, or there is one called bendamustine and rituximab. We'll talk about the R part in a couple of slides. But again, typical side effects you might expect from these are nausea, hair loss, fatigue, low blood counts, infection, nerve pain, rash, blood in your urine, or even in some cases, some of the drugs can cause heart failure. One thing that is important to keep in mind about these drugs is there are some long-term potential side effects of the drugs, and they include bone marrow damage. And so people who may be in remission from the FCR, we want to check and make sure that we're looking at blood counts, and if somebody becomes anemic or has some abnormalities in their blood counts, we want to make sure that this doesn't represent a toxicity from prior chemotherapy. One thing that is nice about the classic chemotherapy regimens is that they typically come in cycles. And, for example, we might do 6 cycles of therapy over 6 months, and then the therapy is complete until we need another treatment for CLL at a different time. So immunotherapy is something that is commonly combined with the standard chemotherapy agents. Essentially what we're doing with these are we're trying to specifically target something that lives on the outside of a CLL cell. So Dr. Hu had the graphic of the little markers that live on the surface of CLL cells. The drugs that are currently approved are called antibodies. And the antibodies that are currently approved for CLL attack something that lives on the surface called CD20. You guys may have heard of them or have had these drugs before. They include rituximab, ofatumumab, and obinutuzumab. And obinutuzumab is also called Gazyva. Some people know it by that name. Basically, I have a picture here of what an antibody looks like. Essentially, the top portion of it goes out and recognizes the marker CD20 on the cancer cells, and then the other part basically signals the rest of your immune system to attack and take care of that cancer. Of course, you probably, those of you who are my patients, and when you're reading about this, you are probably hearing a lot more about targeted cancer therapy. And the goal of this is to avoid killing normal cells and going after the cancer cells specifically. When I talk about targeted therapy, I'm specifically talking about ibrutinib, acalabrutinib, idelalisib, duvelisib, and venetoclax. Although we're going to talk about some of the newer up-and-coming treatments as well. I wanted to spend some time talking about the B-cell receptor blockers, and those include the drugs ibrutinib or Imbruvica, acalabrutinib or Calquence, idelalisib or Zidelig, or duvelisib. Natalie had mentioned these drugs before. They are B-cell receptor blockers, or they specifically inhibit something called Bruton tyrosine kinase. And so sometimes they're called BTK inhibitors. And so essentially what I want to think about that it's doing is these B cell receptor signals, or these Bruton tyrosine kinase symbols, are essentially, they are telling your CLL cells to stay alive. And so we're blocking that signal. And so we're essentially taking the gas out of the car. Right now, ibrutinib and acalabrutinib are available for any patient who has CLL that requires therapy. And the drugs idelalisib and duvelisib are a class of drugs called PI3 kinase inhibitors, and they're only available in second line or higher. I wanted to spend just a moment talking about ibrutinib and some of the possible side effects, because those of you who are on it, you know, it is actually a pill drug. And a lot of times when people think of pills, they think maybe these drugs are a lot less toxic than the chemotherapy that comes through the vein. I often agree with you, and I do think that ibrutinib is much better tolerated than most of our standard chemotherapy drugs. But one point to know about ibrutinib and acalabrutinib are, once you start the drug, they're meant to be taken indefinitely. And what that means is, as long as the drug is working and not causing any serious side effects, you are meant to continue on that drug. So some people say, gosh, does that mean I have to take it forever? And, you know, the answer is probably no, because, you know, with as fast as we're developing new drugs, wait a couple more years and we might have come up with something better or something different that we don't need to take continuously. But at this point, I plan on people to be on these drugs for long term. Some of the common or mild side effects that people get are low blood counts, diarrhea, nausea, bruising, muscle and joint pain, or sometimes infection. And the majority of these side effects I find are worse during the first month or two that patients are on therapy. And so that's why I really want my patients to know about these side effects. And so if they experience them, not to just stop the ibrutinib on their own, but to let me know about them so we can work through it, because sometimes we need to hold the drug temporarily. It's possible we may need to reduce the dose of the drugs. But often if people can make it through the first couple of months on therapy, they can be on the drug long-term with little side effects. I did want to mention some of the rare or more serious side effects. So ibrutinib interferes with the process of blood clotting. And so very early, before we knew this about the drug, there were some cases of deadly bleeding where patients, often it was patients who were on a separate blood thinner called Coumadin at the same time, which increased their bleeding risk. And it's possible to have bleeds in areas that can't take much bleeding, like the brain. Now, I find that this is really rare now, but the more common thing I see is just increased bruising on people's skin. We do recommend that if you're planning to have a major surgery, like a knee replacement or a hip replacement, something like that, we do recommend holding ibrutinib for 7 days before and 7 days after the procedure. If you're planning on having just a very minor procedure, we may only need to hold it for 3 days before and 3 days after. Atrial fibrillation is an irregular heart rhythm that's actually generally pretty common. You probably have even heard advertisements about it on the television. This happens in about 6% of patients where they get an irregular heart rhythm. Most often, I don't have to stop people's therapy for this irregular heart rhythm, but we need to make decisions about, how do we keep the rhythm low enough that it doesn't cause you symptoms, and answer questions about, do you need to be on a blood thinner to prevent stroke while you have the atrial fibrillation. One thing that I found, this high blood pressure that you get along with ibrutinib, it does not decrease over time, and in fact, it actually increases over time. And so sometimes we actually end up having to place patients on blood pressure medications while they're taking ibrutinib, just because, as a long-term drug, we also want to make sure that we take care of your general health, and having uncontrolled high blood pressure is very hard on the kidneys and blood vessels. Although I'm mentioning these side effects, I think that this is a very good drug. There is some evidence that ibrutinib actually enhances your immune system, so it makes you at a little lower risk of infections. you know, there are some data, as Natalie mentioned, there are some studies that include ibrutinib and acalabrutinib, looking at decreasing the inflammation in the lungs of patients who have coronavirus infection. And so there are lots of studies that are ongoing looking at if these drugs can actually decrease the course of coronavirus and decrease the severity. And so generally at this time, based on what we know now, in patients on ibrutinib or acalabrutinib, if they're not severely ill from coronavirus, I do recommend continuing this drug throughout their coronavirus course. Now, of course, if you're on mechanical ventilation or, you know, very severe disease and can't take a pill, then that's a different story. But generally, if you have a mild case of coronavirus, I would recommend continuing this drug. The next really exciting drug I want to talk about is venetoclax. And the concept of this drug is that cancer cells have proteins that prevent cell death. So, you know, we've talked about that cancer wants to grow more quickly than normal cells. It also doesn't want to die so that those cells can hang around. And that's why you get these high white blood cell counts or, you know, enlarged lymph nodes, because those cells aren't dying off. They're just sticking there. So venetoclax blocks BCL2 or the protein, and so that the cancer can go ahead and die. And so as those of you have heard me talk about it before, I always think of it as the Thelma and Louise drug, because it's like taking your foot off the brake and driving over a cliff. This drug is now approved for all CLL patients. If you're using it in the frontline setting, it is used with the antibody called obinutuzumab or Gazyva. If it's used in later than frontline setting, it's used with an antibody called rituximab. One of the things to know about venetoclax is I will say that this drug is fairly well tolerated. One of the things that we talk about a lot up front when you start the drug is that there's something called tumor lysis syndrome. And this essentially is a concept, and over here, these green cells are meant to represent CLL cells. And essentially, whenever you give the drug, all of those cells can break down, and they release things that normally should be on the inside of the cell out into the bloodstream. Those things can be toxic to the kidneys. And so those are things like uric acid, and you can see in the graphic that can cause kidney problems. They can include phosphorus or high potassium, which can cause irregular heart rhythms or even seizures. And so that's why this drug, when we started, we actually started a very low dose, and it takes us about a month to ramp up to the planned dose of this drug. If people have a really high tumor burden, meaning large lymph nodes or, you know, white blood cell counts that are high, sometimes we actually have to admit people to the hospital for observation so that we don't have this problem. With the ramped up dosing and, you know, being cautious with patients, I really only see, you know, usually laboratory evidence of this, and people generally don't have kidney problems, heart problems, or seizures if they're closely monitored. This is only a problem really during the first month of the treatment. And, you know, one thing that's nice about this drug, once you get through that portion, it's a lot easier going. And one of the great things about venetoclax is that it is designed to be a limited course of therapy. And what I mean by that is in the frontline setting, you would take this drug for a year and then stop therapy. And we're aiming for something called that minimal residual disease undetectable that I talked about previously. If you're taking it in second line setting, you take it for 2 years, and then we plan to stop the drug. So I'm going to move on to talk a bit about clinical trials because we have some exciting things moving forward. And for those of you that may not know much about clinical trials, I want to talk about the difference between standard of care and clinical trials. So what drugs we consider standard of care mean that we can write a prescription for them, or we can give you them in infusion. These have been tested extensively in people. We know that they're safe, or we know what toxicities to expect. And we know that they work well, and they've been approved by our governing agency, which is the Food and Drug Administration. So clinical trial is actually the process of testing drugs in people. We have 3 main phases of clinical trial. A phase 1 drug trial means is the drug safe? And so it may be the first time the drug is tested in people, or it may be the first time it's tested in combination with another drug, or it may just be the first time it's tested in CLL. For example, maybe it's approved in another type of lymphoma, but hasn't been approved in CLL. Once we know that it is safe and it's passed through phase 1, we get to phase 2. And that basically means how well does it work? So we know it's safe. We want to know what are the response rates? How well do people do on these drugs? Once we know that it works really well, we move into phase 3. And our question is this better than what is the standard of care? So usually we have a trial where we randomize people to the new drug versus a drug that's already approved. And once it passes through phase 3, it becomes the standard of care. And so, you know, just a note to those of you who are participating in clinical trials, you know, I certainly hope it's always of great benefit to you, but just know you're really benefiting a lot of people, because if you participate in a trial that makes a drug a standard of care, you open up the possibilities of many people across the country and even across the world actually being able to use that treatment. And all of the standard drugs that we have right now went through the process of clinical trial testing. So some people ask me about clinical trials when I start to talk with them. They say, am I a guinea pig? And no, you're not. There are lots of very detailed safety protocols that we go through. There are lots of testing in animals before these drugs even make it to human trials. And so we do everything we can to make it as safe as possible during these trials. Some people ask if they're going to be given a placebo or a fake or a sugar pill. And in general, the majority of our trials for cancer do not involve placebos. Usually if you're randomizing between one thing or another, if the standard of care is not to do anything, you will know that. You generally won't be given a placebo pill. And of course, since right now we don't have any cure for CLL, clinical trials are really important. So again, I want to thank all of you that participate in them and are interested in these trials. Right now, some of the hot clinical trials are drugs that involve combination of these new drugs. So obinutuzumab, the antibody that I mentioned, ibrutinib or acalabrutinib. There's another similar drug that is likely going to get approved in CLL called zanubrutinib, and venetoclax. And so right now, and some of you I know who are on this call are actually participating in this clinical trial, but we have a really great and really beneficial clinical trial that's going on throughout the country right now for frontline treatment of CLL. So if it's your first treatment and you meet criteria for treatment, there are 2 clinical trials. I put the schema up here to kind of represent what it is. It's basically untreated patients sign up for this trial, and they get randomized to either receive 2 of the new drugs, ibrutinib and obinutuzumab, versus 3 of the new drugs, ibrutinib, obinutuzumab, and venetoclax. So at this time, we're not sure if 2 drugs is better or if 3 drugs are better. And we want to do this trial to compare how long do people have responses and make sure we take into account quality of life and side effects. In this trial, there is a trial called the ECOG study, and this is for patients who are under 70 years of age. In the 3-drug or experimental arm, the ibrutinib stops after 19 months. So it's a limited therapy, whereas in the standard arm of ibrutinib and obinutuzumab, the ibrutinib continues indefinitely. And the Alliance trial is for patients who are 70 years of age or older. After 15 months, you actually stop and try to detect this minimal residual disease that I talked about. If it is undetectable, then you get randomized to either continue ibrutinib or stop it altogether. So it might be a limited therapy in that arm as well. If you have detectable residual disease, then the ibrutinib is continued. I think I just highlighted it in red on this slide because I think the most incredible thing about this study is the cost savings it has for patients. So all of these really expensive new drugs are completely paid for by the study, and they are paid for as long as you're on the trial. And so those people who are on indefinite ibrutinib as long as they're on the trial, they never have to pay for their ibrutinib therapy. And I think that that is incredibly great benefit and very generous. This study is open, and so, you know, in case you are getting ready for frontline therapy, I would really suggest that you ask your doctor about this treatment option. I suspect that these studies will probably be open for another year or so to accrual, but they are accruing quickly across the nation because they're such good studies. There's another study that I'm very interested in, and we're just seeing that this study is going to be updated at our annual meeting this year. And this is called the Captivate study. And this is a combination where patients receive ibrutinib for 3 months, and then they go on ibrutinib plus venetoclax for 12 months. And then we do this test called MRD. If MRD is undetectable, you get randomized to either receive ibrutinib or placebo. If MRD is detected, you either continue just ibrutinib or you continue the combination. This study is ongoing, but it's kind of an exciting way to approach it with the combination and the potential to stop therapy so that you don't have to be on indefinite therapy. Again, more details to come about this. When they have our national meeting in December, we'll probably have some more data available on this study. The other thing I want to mention is that, you know, some patients say, gosh, you know, I'd really like to be off of ibrutinib. Is there anything that we can do? And so we do have a study that looks at a strategy to deepen remissions on ibrutinib. This is a drug called VA736. It is an intravenous drug. And essentially we add this infusion, and it's every 2-week infusions for 6 to 9 cycles. Basically what the drug does is it's just another way to block survival signals. And so it has some additive effects with ibrutinib. If you go on this study and use the extra drug, the VA736, and all the CLLs are cleared, meaning MRD undetectable, the plan is to stop both drugs. And so it does give a kind of an option to discontinue ibrutinib. And so the status of this study is it is open for patients who have been on ibrutinib for greater than a year and have not yet achieved complete remission. And so if it's something you're interested in, you're on ibrutinib, make sure to ask your doctor about this study because it is open and enrolling. I do want to spend just a little bit of time on a future clinical trial. And when I say future, I mean very near future because we're very close to opening this study. This is a study called the EVOLVE study. This is a trial because we thought, you know, all of these new drugs are so great. Would it make a difference if we looked at patients who have really high-risk disease, like what Dr. Hu was talking about, some of your risk factors, and try to determine, should we treat people early with venetoclax and obinutuzumab? So this is only for patients with high-risk disease who don't meet any criteria for CLL therapy, have not received any prior CLL therapy, and they need to have deletion 17p, TP53 mutation, or a combination of clinical and genetic risk factors, which if you think you might fall into this group, I would encourage you to ask your doctor about it. You must have been diagnosed with CLL within the last year, so there is a time limitation on it. Essentially, when people enroll in this trial, they will be randomized to either receive venetoclax and obinutuzumab regimen for 1 year immediately, or to wait until time of treatment is indicated based on symptoms or low blood counts. This is planned hopefully to open nationally in November of this year. It probably will take our site about a month or so to activate it once we're able to open it. But definitely by the beginning of 2021, we should have this trial available. And so please ask your doctor about it. I'm going to spend just a little bit of time talking about ibrutinib resistance. And essentially what happens is ibrutinib binds to a drug, the site on the CLL cell called BTK, and it binds to a specific location. Once it becomes, your CLL becomes resistant, that site kind of changes in shape, and so the ibrutinib doesn't really fit there. but often we see kind of a very slow progression of increased lymph nodes or a small increase in your white blood cell over time. However, the drug is still working, and so we often see rapid progression after you discontinue ibrutinib, and so please don't discontinue ibrutinib without another plan in place. There are other drugs that I mentioned, acalabrutinib and zanubrutinib, have the same problem with resistance, and so if you are resistant to ibrutinib, you should not be started on acalabrutinib. We have a couple of clinical trials here that are open for some new drugs. There's a drug called ARQ-531. It is also a BTK inhibitor, but it doesn't bind to the same binding site as ibrutinib, and we've had some really great responses in patients who are resistant. There's a drug called a Ming site drug, MS553, which essentially blocks a downstream portion of the BCR pathway. And also, I have patients on it who are doing quite well with. I have patients on both of these trials who are doing very well with these drugs with pretty minimal side effects. And these trials are currently open. We talked quite a bit about CAR T-cell therapy last year, so I just wanted to remind you what that is. Essentially, our cancer cells have these hooks. We take your own cells and train them to recognize these, and then those cells activate your immune system and kill the cancer cell. What looks like for you as a patient, your blood is collected, the T cells are separated in the lab, the CAR construct is inserted into those cells, and then we multiply them. Then we give you some chemo and put the cells back in. This has been a really exciting trial, and we have this trial open here, and one of my patients who's on this trial spoke for us last year, and hopefully he doesn't mind me mentioning that he's still doing very well. But basically, this trial with CAR T, the patients, the data that we published so far, we have 23 patients with relapsed CLL. They had a lot of prior therapies, so up to 11 prior therapies. All of them had ibrutinib, and half of them had venetoclax. 82% of these patients responded, and half of them had a complete remission. And in the 9 that had a response that has more than 9 months of follow-up, there were only 2 progressions. And so really, really exciting data, and more to come on this. Of course, important side effects, cytokine release and brain toxicity. When your immune system gets overactivated, your immune system can go a little haywire and cause things like fever, nausea, chills, low blood pressure, fast heart rate, rash, trouble breathing, and even death. And that's why some patients ask me, well, can I just do it as the first-line therapy for my CLL if it looks so promising? But we still need to make sure that we have the side effects, especially the ones that cause death, under control. And so that's why it's not widely available to all people. But I do think that this concept will likely be approved in CLL within the next year or 2. So in summary, I feel like I've covered a lot of data. I'm sure there will be lots of questions.